monster showed up just after midnight, as they do. Connor was awake when it came. He'd had a nightmare. Well, not a nightmare, the nightmare. The one he'd been having a lot lately. The one with the darkness and the wind and the screaming. The one with the hands slipping from his grasp, no matter how hard he tried to hold on. The one that always ended with, "Go away," Connor whispered into the darkness of his bedroom, trying to push the nightmare back, not letting it follow him into the world of waking. "Go away now." He glanced over at the clock his mum had put on the bedside table. 12:07, 7 minutes past midnight, which was late for a school night, late for a Sunday certainly. He'd told no one about the nightmare. Not his mum, obviously, but no one else either. Not his dad in their fortnightly or so phone call. Definitely not his grandma, and no one at school. Absolutely not. What happened in the nightmare was something no one else ever needed to know. Josh, that was an excerpt from the award-winning book A Monster Calls by Patrick Ness. And the relationship to our topic is a little bit oblique, but it was based off an original idea by the British writer Siobhan Dowd, who very sadly passed away from breast cancer, which before the book could actually be written by herself. So as many of our listeners who have read the actual book will know, it deals with the very sad subject of grief and a boy's manifestation of it when his mother is dying of breast cancer, which leads us into our very sad topic today, but it is metastatic HER2 positive breast cancer.
Michael, thank you for a very interesting introduction. I personally can say I had no idea where you were going with this, but I am pleased to announce that our topic today is not as sad as how you've portrayed it.
No, it's not. Do I need a new introduction?
No, I really enjoyed it, but I think for the listeners here today, I'm Josh. This is Michael. Welcome to Oncology for the Inquisitive Mind. Michael, did you want to start with your intro to our topic today?
Yeah, so we're talking about HER2 positive breast cancer, and I guess the reason I chose that very grim introduction was that prior to the advent of Herceptin, the development of Herceptin in the early to mid 90s, HER2 positive breast cancer was a very nasty disease. It was very aggressive. It was very difficult to treat. It was frequently chemo refractory. And most horrifyingly, it made a beeline for the brain and the CNS. So very early on, patients would have CNS metastases, which was obviously incredibly crippling for both quality of life and survival. Happily, though, there is a lot of new data, a lot of established data, and all of it built on the bedrock that is Herceptin. Or trastuzumab, as we should say, because 20 years in the future, Herceptin might not be a brand name, so it's trastuzumab, not Herceptin. But built on the church that trastuzumab created, we have much more effective treatments for this. And the main, or the current standard of care, at least in Australia, was pioneered by the first study that we're going to talk about, which was Cleopatra. Josh, with your executive permission, I'll launch right into that.
I can't wait to hear about the advances that we've made in this one specific subset of cancer. And I want to say one thing. These are great treatments. And I'm so very excited to hear about Cleopatra. Plus, all the trials to do with HER2 positive breast cancer have fantastic names.
They all do. I mean, it's almost a thing that is, it's very common in cancer, but it seems like the breast cancer treatments have the best names. Cleopatra, Monarchy, Catherine, Paloma. I almost said polenta, but that's a kind of chip. Paloma, and they all have such great names. Affinity.
Do you think that the drug companies sit down, have a room for like public relations and media officers, and they actually think about how to name these trials?
You would have to think, and I was thinking about this the other day actually, you would have to think that they have the catchy name first, and then they work out a way to cram something that is vaguely close to what they're actually looking at second.
So it's almost like having a database of great trial names with nothing to go in them, and then you fill the box, and inside the box is hopefully a really good trial and a really good outcome.
Yeah, we hope so. We hope that the trial's quality definitely reflects the awesomeness of its name, which is definitely the case in Cleopatra. Our loyal listeners will remember that last week Josh talked about the Neosphere trial, which was a phase 2 study looking at docetaxel, pertuzumab, and trastuzumab, which is a dual HER2 blockade, which was demonstrated to be more effective than just trastuzumab alone in the creation, I guess, or achievement of a pathological complete response. The regimen that they used in that trial is exactly the same as the regimen they used in Cleopatra. So it is docetaxel plus trastuzumab and pertuzumab versus docetaxel plus trastuzumab alone. A hypothesis was that the dual HER2 blockade would increase the effectiveness of what was already a pretty good standard of care. Just for reference, the overall survival in the control group, and the reason I'm putting this first is to set the scene, I guess. The overall survival in the control group in Cleopatra was 40 months. And this is from data from the end of study publication. So we're already looking at over 3 years, pushing 3.5 years. So how much better can the addition of pertuzumab do? Our listeners will have to listen on to find out.
I wait with bated breath.
Bated breath indeed. So Cleopatra was a randomized double-blind placebo-controlled phase 3 trial which enrolled patients with locally recurrent, unresectable, or metastatic HER2-positive breast cancer. Eligibility criteria, obviously, you had to be functionally good. You had to have an ECOG status of 0 to 1, a left ventricular ejection fraction of greater than 50%. Again, long-time listeners, or at least listeners who listened to last week's episode, will know that we spoke at length about the potential cardiac toxicity of trastuzumab and, to a lesser extent, pertuzumab. They had to have had no more than one hormonal treatment for metastatic disease, obviously in those who had hormone receptor positivity. But adjuvant or neoadjuvant chemotherapy was allowed. Interestingly, they put a limit in the time to recurrence. So there had to be an interval of at least 12 months between the completion of prior therapies and the diagnosis of metastatic cancer. I'm not exactly sure why they stipulated that. My guess is, again, to filter out the people with really bad, really nasty disease that recurs quite quickly and to establish potentially a therapeutic baseline. But that's just me spitballing there. Exclusion criteria were so patients with CNS metastases were not allowed, which I guess is important. As we said, HER2 positive breast cancer makes a beeline for the CNS and for the brain. They also, unlike some other studies that we have or will look at in the future, they didn't stipulate that patients with treated CNS metastases were allowed. So from reading the article, it does seem like a blanket ban on anyone with CNS disease. Patients, obviously, who had a reduced left ventricular ejection fraction or previous treatment for metastatic disease were also excluded. And this is a marker of how good this study was, is the benefit of the addition of pertuzumab became obvious fairly early on, I think, the first or second interim analysis. And after it was demonstrated, patients receiving placebo who had not progressed were invited to cross over and receive pertuzumab. But these patients were still analysed in the intention to treat population in the initial publication. So if anything, that might actually reduce the magnitude of benefit for pertuzumab because you have some patients who initially had placebo but then get some survival benefit from pertuzumab. hypothetically.
Did you want to discuss, and this is something that's confused me or has confused me in the past, the difference what intention to treat means in a crossover, this idea of crossing over and the differences in outcomes based on the ability of people to cross over to the intervention arm?
Yeah, look, my knowledge of this is by no means extensive, but by my understanding, the intention to treat population means that patients are analysed in the group to which they were originally assigned, which is fine and very easy if you don't allow crossover. So, you are in the placebo group, you continue in the placebo group until you come off trial, and then maybe you can get the trial drug if it's been approved. And so patients who are, so say you have two patients, one is patient A who's in the experimental group, and patient B is in the placebo group. When you're looking at intention to treat analysis, patient A is always in the experimental group, and patient B is always in the placebo group. The difference is your patient B's statistics are still going to be in the intention to treat group, regardless of whether crossover is allowed. So if patient B does really well in the placebo, taking Cleopatra's case, and then subsequently gets pertuzumab, if we're looking at intention to treat populations, the survival of patient B, which may partially be to pertuzumab, is still counted as the placebo, as the comparator. So sometimes we have this sort of wink, wink, nudge, nudge, the statistics are actually better because patients were allowed to cross over and get some benefit when they were receiving placebo.
That was a great explanation. And I think I do need to highlight here that, Michael, when you look up the definition of intention to treat in Google, that comes up.
And will you believe, Josh, that I do not have Google on or open at all? That's
word for word.
Just off the top of my dome. Just
Just amazing, as always.
Why, thank you. Stop. The primary endpoint, sorry, just let me get my massive head back on my shoulders. The primary endpoint for Cleopatra was progression-free survival, but it was published initially in 2015. And so we do have good long-term data in the areas of overall survival as well. Other secondary endpoints were overall response rate and safety. Just a few notes on the demographics. So in total, there were 808 patients from 204 centres in 25 countries that were enrolled, and they were randomised 1-to-1. The protocol stipulated, or recommended, I should say, didn't stipulate, but it recommended that at least 6 cycles of docetaxel be administered, if possible. The median age of patients was 54, and this really sort of demonstrates what a heterogeneous and wide-ranging group breast cancer patients are, Josh. The age range, and we don't normally say this, but the age range in the placebo group ranged from 27 to 89, and in the pertuzumab group, 22 to 82.
That's insane, just that reference range.
Yeah, absolutely. And if you look at studies, quite a few studies do get patients in the 80s, because you will get, and working at a trial center, you do see this. You have these fantastic people in their 80s who have the body and mind of a 60-year-old. It's the 27 and the 22 range that really gets me, and the fact that we don't say, oh, that's an outlier. We do have patients who are frequently in their early, mid, late 20s who are afflicted with this disease. It shows how important these treatments are. The majority of patients, so 77, 78% of patients in both groups had visceral disease. So we're talking quite advanced disease, obviously not CNS metastases. And there was an even split between hormone receptor positive and hormone receptor negative, approximately 50%, give or take. As Josh mentioned last week, the actual diagnosis of HER2 positivity, and this is something that he will come to in his study, the actual diagnosis of HER2 positivity was made for the vast majority either being 3+ positive on immunohistochemistry or positive on FISH, so that's fluoro in situ hybridization. In terms of prior adjuvant or neoadjuvant chemotherapy, about half of patients hadn't, so these are patients who presented de novo metastatic. In terms of the patients who had, the majority had had an anthracycline, about a quarter had had taxane, and only about 10 to 11% had had trastuzumab, which I can only really explain as being as the time that this study was produced, in that the use of adjuvant or neoadjuvant trastuzumab had not yet reached the public. But it was 2015. I was just out of med school, so I could be entirely wrong on that point. Let's come to the meat of this study, which is the results. And because they're so good, we'll focus purely on the experimental arm. So that's the dual HER2 blockade. The progression-free survival was 18.5 months, and hazard ratio compared to the trastuzumab alone arm of 0.62, which was observed in all predefined subgroups. Though if we're trying to pick holes in the subgroups, the group that appeared to benefit least was patients with non-visceral disease, with a hazard ratio of 0.96. And that's probably because they're getting such a great outcome out of the trastuzumab, the addition of pertuzumab is not adding too much. Among patients who had received previous therapy with trastuzumab, the PFS was 16.9 months versus 10.4 months, with a hazard ratio, again, of 0.62. The overall response rate was 80% versus 69.3%. 74% of patients in the dual HER2 blockade had at least a partial response, and 5% of patients had a complete response. And I have seen a couple of complete responses from this regimen, Josh. I don't know about you.
I have, and it's what's even I find crazier is that this is a sustained complete response. You don't see it for a month or 6 months. You'll have patients who have complete response for years, and apart from coming in for an infusion every 3 weeks, you don't know they have cancer.
Yeah, and if we are getting to the point with HER2 positive breast cancer where the worst part of the disease is a minor inconvenience, then we are kicking goals, absolutely. Where's a sufficient amount of time beyond the original publication that we have data from an end of study publication from 2020 that focuses on the overall survival. And the median overall survival, you might remember the control group overall survival was 40 months. Well, hold on to your horses, because the experimental arm's median overall survival was 57 months. The 5-year survival for the control arm was 45%. The 8-year survival was 37%. So almost 4 in every 10 patients with metastatic HER2 positive breast cancer, this awful, aggressive, nasty disease, are living 8 years and beyond.
Apart from melanoma and potentially that small population of resectable oligometastatic colorectal cancer, can you think of any other cancers that have a 37% alive at 8 years with metastatic disease?
Metastatic disease? Probably not. I can't.
I mean, there are some long responders in lung these days with immunotherapy, but
there are
it's
some
a
long
very
responders with renal cell, again, sort of about 1 in 5. I mean, prostate cancer, maybe. But even prostate cancer. Yeah, but even prostate cancer, 8 years is pushing it.
Yeah, it's just amazing. But sorry, I just really want to emphasize how incredible this data is.
Oh, there's plenty of emphasis to come. Plenty of emphasis to come, my friend. In patients who had previously received trastuzumab, so these are patients I think that are worth highlighting because there is potentially a thought that because they have recurred after receiving trastuzumab, they might be more resistant and present a poorer outlook, or be beholden to a poorer outlook. In those who previously received trastuzumab, the median overall survival was still 53 months versus 46 months in the control group. Hazard ratio of 0.86, so not quite to the same degree of benefit, but still significant. The median number of treatment cycles, again, it's not something we normally focus on because normally it's like 3 or 5. In the experimental group, it was 24. But here's the number that's really going to blow your socks off, Josh. The maximum number of cycles was 167.
I officially have no socks.
Josh has no socks anymore. So I did some very simple arithmetic, and yet I still needed a calculator. That equates to 9.6 years of treatment.
Absolutely marvelous, those results. And I think if I was the researcher and that founding researcher group from 12 plus years ago who developed these drugs, or in pertuzumab, I guess, but trastuzumab in combination with pertuzumab, I would happily know that I have made a huge impact on the world of so many women and so many families and just people in general.
There's an argument as well that this whole sort of the Herceptin, which was really the origin of targeted therapies, where we find a cancer marker, a hat that the cancer wears, and specifically target that has done more for cancer treatment and a greater sort of magnitude for cancer treatment than immunotherapy. Controversial opinion of the week.
Oh, would I agree? I've just said I would agree, and now I might backtrack on agreeing. I think the future is that if we find a targetable mutation, like let's say osimertinib in the EGFR, or the next generation of treatments that have minimal toxicities and huge benefits, you're going to go with that. The thing is, looking at colorectal cancer, they've looked at HER2 therapy. It hasn't been overtly successful, despite being able to identify that receptor. But the drug I'm talking about, and we're not going to talk about that trial, has actually found some cross-reactivity with the HER2 receptors in colorectal. So this, once we understand the proper biology, which is going to take years,
decades.
These even. Are going to be decades. You and I might be retiring by the time something else as amazing comes out. But this will be the future.
Yeah, no, absolutely. And I guess the best part of this is the side effect profile, I guess, was, to borrow a term from so many studies that I've seen, very acceptable. We saw this a bit in Neosphere. Sure, there is significant instances of diarrhea, alopecia, neutropenia, nausea. But all of that is from the docetaxel, which patients were going to get anyway. The actual additional toxicity from the addition of pertuzumab is very minimal. Now, docetaxel is not the nicest of chemotherapies. That's it. I never thought I'd say that, but it is not the nicest of chemotherapies. There are a lot of toxicities, and a lot of patients do find it hard to tolerate. But I guess the docetaxel, given you're only getting 6 of up to 167 cycles with docetaxel, and the rest is trastuzumab and pertuzumab, it's probably a relatively small contributor to the overall therapeutic benefit, but it is overrepresented or overblamed, I guess, in terms of toxicity.
I think that's an interesting point you bring up. Remember when we were talking about Neosphere, and they had the 4 arms, and they looked at the treatment without the chemotherapy, which showed the effectiveness to be less. So the question I have is, could we potentially prime this cancer with a different chemotherapy agent that hasn't been put in these trials? Even have, a head-to-head of docetaxel versus, let's say, paclitaxel, which we use very regularly, and yes, potential toxicities and potential neuropathy as a side effect. But I find the weekly Pacli is generally tolerated okay.
Yeah, I mean, docetaxel can cause, because they're the same family of drugs, it can cause a lot of the issues that paclitaxel has. But I agree, the degree of particularly myelosuppression and nausea, and I mean, alopecia is probably equal, but myelosuppression and nausea, vomiting, diarrhea is significantly worse, generally speaking, in patients receiving docetaxel than paclitaxel.
I like to say generally speaking, because we always have cases where the paclitaxel is very debilitating, and we have to be like, well, I guess we were wrong.
You're in that group of patients that just can't tolerate paclitaxel.
Yeah, which is hard.
Okay, so summing up Cleopatra, because amazingly, this is probably not the most incredible study that we're going to be talking about today. It is a improvement on an already fantastic treatment, but it sends that fantastic treatment into the stratosphere with very few additional toxicities. And so has been adopted as the standard of care, first line for HER2 positive metastatic breast cancer. But Josh, there's a new kid on the block, a kid that threatens to make all of everything that I've said in the last half an hour or so completely redundant. So why don't you talk to us about Destiny?
The future is among us. But
That's aliens, Josh. Aliens are among us.
yes, okay, aliens are among us. This I'm so very excited to talk about Destiny Breast 3. Michael did briefly mention something to do with HER2 positivity, and I will talk about that at the end of my discussion, but that's actually Destiny Breast 4 and wasn't included in this trial. So, Destiny Breast 3 was a phase 3 multi center open label randomized active control trial, which evaluated the efficacy and safety of trastuzumab deruxtecan or TDXD compared with trastuzumab emtansine. Now, we haven't spoken about TDM1 in this podcast, but we did talk about in the previous podcast. And this is in patients that are HER2 positive, they're unresectable or metastatic, and they have progressed through their progressed during or after treatment with trastuzumab and a taxane in the context of advanced or metastatic disease, or have progressed within 6 months after neoadjuvant or adjuvant treatment involving trastuzumab and or a taxane. These patients were randomized 1-to-1 to receive either TDXD or trastuzumab emtansine. Any questions so far, Michael?
Absolutely none, Josh. You're doing splendidly.
Thank you. I'm excited. The one of the inclusions, Michael, and potentially different to your trial, was that brain metastases were eligible to be enrolled if they had clinically stable or previously treated disease, which is good. And I think this needs to be included in most future trials because, as you said, it takes a beeline for the brain. There are a lot of patients who have metastatic brain involvement, and that shouldn't preclude them from what could be a life changing treatment, along with the fact that we want to know if it's effective in this kind of metastatic breast cancer with brain involvement. Exclusion criteria was that if they had symptomatic brain mets that required treatment, if they had previously been treated with the HER2 antibody drug conjugate, including TDM1 in the context of metastatic disease, had a history of interstitial lung disease, which is interesting, or suspected interstitial lung disease, which for some reason I am struggling to pronounce. I will call that ILD. The primary endpoint was progression-free survival as determined by blinded independent clinical review. So just progression-free survival, that's all you need to remember. And the key secondary endpoints were overall response, they've got progression-free survival as the second time, and safety. I'm not exactly sure why. Maybe I just copied that over. But either way, recruitment occurred between 2018 and 2020, 524 patients, similar to Michael's trial, 169 centers, 15 countries. They went all out with this. Things to note is that they did identify HER2 positive status. So about 90% in both arms, the intervention and the control, had 3+ HER2 status. This is based on, I think, ISH positivity. And there was about 10% in each arm that was HER2-ish, and most of them, the HER2-1 positives were excluded, really, by the looks of it. Half of the patients were ECOG 0 or ECOG 1, and hormone receptor status positive, so that's ER and PR positivity, was about 50-50 in both groups. What I did want to highlight here is a number of previous lines of therapy. Michael, what do you think was the average number of previous therapy lines for this trial?
Average number. You see, based on current sort of standard of care, where when the Cleopatra regimen fails, we do go to TDM1 as second line, and that's what the control arm was. My gut says too, but the fact that you're asking such a leading question makes me think it's more likely to be about 4 or 5.
I was just being mean. The the majority of previous lines is actually one line of therapy. So about 50% of each arm had at least one line of prior therapy. Whereas if you're looking at 2 previous lines, it was about 20% plus, and then 3 prior lines of therapy was about 13%. But there were those that had 4 prior lines of therapy and 5 prior lines of therapy. As expected, most prior patients, or 99.6%, had previously been treated with trastuzumab, and about 2/3 with pertuzumab as well. This is an amazing study, and I'm just going to I'm going to take a beeline to the results, because this is the gold standard.
Gonna make like a HER2 and make a beeline for the results.
Make like a HER2. So median progression-free survival was not reached in TDXD. That's the best thing, right? And in TDM1,
that's just insane. Sorry, that is just insane.
Now, I think it's also important to note, I haven't put it in my notes, but the thing is that at 12 months, the percentage of patients alive without disease progression in TDXD was 75%. And that's compared to 34% in which was the best second line therapy we had.
But Josh, just to put that in in the terms of a conversation you might have with a patient, is that with TDXD, with trastuzumab deruxtecan, the likelihood of you still being alive without progression, which is a completely different story than just being alive without progression, so the treatment is still working at 12 months, is 3 out of 4.
Yeah, so 3 out of 4 women will be alive with realistically well-controlled disease and no progression.
Just mind-blowing, and this is on pre-treated patients.
Yes, and this is double TDM1, and the hazard ratio for disease progression or death from any cause, one of the best I've seen in quite a while, was 0.28.
That is right. A hazard ratio king amongst hazard ratios.
And investigator assessed median PFS was 25 months, but again, it could not be estimated the maximum with TDXD, compared to 7.2 months with TDM1. Again, a hazard ratio of 0.26, so even better. If you go to the forest plot analysis, which I like looking for, it takes a sharp detour to the left in favor of TDXD. This is I'm just going to highlight the areas where we found a significant benefit. Stable brain metastases, yes. No brain metastases, yes. Lines of previous therapy, more than 2, still benefited with a hazard ratio of 0.28. Organ disease, still benefited with a hazard ratio of 0.28. Previously treated with pertuzumab, still benefited with a hazard ratio of 0.3. And these aren't small numbers, Michael. So the pertuzumab, 300 patients had previously had pertuzumab. So big numbers. Hormone receptor positive status, which, as we might know or might not know, this is another driver for these sorts of breast cancers. So the ER/PR can drive the breast cancer as well as the HER2. Hazard ratio, 0.32.
Yeah, so we do like poking holes in forest plots on this show, but you frequently do see the widest ranges and frequently the biggest treatment in subgroups that have 30 out of 800 patients. But for the fact that this is amongst heavy hitters with people with brain mets and large groups is just extraordinary. Josh, why do you think trastuzumab deruxtecan is so effective where TDM1 is less? Because they're very similar, I guess, from a what's the word I'm looking for?
Mechanism, perhaps?
Yeah. At a very basic level, they are very similar. So what is the difference between that makes these incredible hazard ratios possible?
Well, that's a really good question, Michael. Thank you for throwing me down on the spot with something that's very basic sciences, but I suspect it's the way they've designed TDXD. So yes, it's an antibody drug conjugate, and yeah, probably works similar to the other ones, but this is linked to a topoisomerase 1 inhibitor payload. And it's unique that it has a high drug to antibody ratio, approximately 8, that remains stable. So what this means, and I suspect this is why it's so effective, it's like you've got a little truck and it takes it to the cell, and you're like, I want to kill the cell. Rather than taking a single little drug to the cell, you can take 8 times that amount. So it is going to be so much more toxic and selective to those specific cancer cells. And it's cleaved by the lysosomal enzymes that are overexpressed on the cancer cell. So, in summary, I suspect the reason why is that your payload, or your ability to deliver this drug without that many toxicities, or, the concentration that you're delivering, is just huge.
Yeah, definitely. It packs a bigger punch. It's Mike Tyson compared to you, Josh. But
Thanks so much, guys. Appreciate it.
but much also like Mike Tyson, it also has a significant bystander effect where it's not just the cell into which the payload is delivered that is affected, it is the cells around it. And this is something that has been noted very much with TDXD, less so with TDM1, that the punch is more effective, but each punch is also creating like a shockwave that that affects multiple cells, not just the one that is targeted. So it's more bang for your buck in multiple ways as well.
That is exactly right, Michael. And so much bang for your buck. If every drug was like this, and I want every drug to be like this, my job would be a lot easier. Moving on. A couple of other things I would like to talk about. Median overall survival, as expected, it was not reached in either arm, guys, and it's way too early in this cohort. But 12 months overall survival, the percentage, so 94% are alive at 12 months based on TDXD, and 85% on TDM1. Both phenomenal 12-month survival percentages, but just something to, I guess, be aware of. Toxicities. There were toxicities in TDXD, and I think that is something to note. Neutropenia is far more common in TDXD, along with far more nausea of any grade. Look, high level nausea, not a lot, but nausea can be quite debilitating and preclude people from treatment. But you also got more diarrhea, there was more vomiting, there was more constipation, there was more fatigue, there was more LFT derangements, there was more alopecia. This is in comparison to TDM1, everybody. So yes, the treatment was so much more effective, and yes, the toxicities are not as bad as you'd expect for the amount of payload that you can do with that bystander effect, but they're definitely there. And finally, don't worry, Michael, I'm going to mention this. I can see it on your face. You're like, Josh, don't forget, we have to talk about pneumonitis.
Yes, I was going to compliment you on your exquisite foreshadowing earlier.
Thanks, Mikey. So, about 10% of patients will get some form of pneumonitis, although grade 3 more is about less than 1%. So not a huge amount, but it is something to be very, very aware of, because you do need to treat this, because this could be a life limiting complication, and you would not want, if these people have survival of years on, well, would have survival on years of TDM1 or TDXD. So you don't want to kind of reduce that by adding another complication to someone's already difficult I guess, a medical list.
Josh, was there any mention of grade 5 pneumonitis? AKA fatal pneumonitis.
They've said just greater than grade 3. I'm assuming there might have been, but they've probably buried it in the notes.
Which I guess is a good thing, because if you look at the early trials with TDXD, the phase 1s, the phase 2s, there was a small but significant number of purely grade 5 pneumonitis, so people who died from pneumonitis. And I suspect this is the new drug syndrome. This is the unexpected toxicity that catches everyone by surprise. And maybe with the first time it happens, they think it's just a quirk, because every drug theoretically can be linked with pneumonitis once or twice, fatal pneumonitis once or twice. But when it started to become a bit of a trend, they said, oh, this is actually an association with TDXD. So the fact that we are now in the phase 3 setting and we're talking about grade 3 to 5 is a good thing, because we're probably much more cognizant of pneumonitis when using TDXD. And, the drug is withdrawn immediately and we start steroids immediately. We're much more aware of it. And I suspect that as TDXD becomes more widely used across the world, it will be something that we just sort of deal with in a similar way we deal with immune-mediated side effects from immunotherapy.
That's exactly right, Michael. And I have the answer for you. There were no grade 5 toxicities in regards to pneumonitis. And they've actually mentioned in the discussion point of this paper that as you said, it's an early drug. We don't have all the answers for managing the toxicities in the early stages, but we do get better at it, including the immune-related adverse events. 2 other things I would like to mention before concluding this podcast.
It's never just one, Joe.
Never just one when it comes to me. Number one, they actually found probably less efficacious in the TDM1 cohort. I think they were comparing it to the original study, and you can't compare studies because it's apples and oranges. They're done slightly differently. They're different cohort of patients. Although they represent our patient load as a whole, it's not indicative. But they did say that the PFS was less. And don't quote me on this, but I think the PFS was less in TDM1 in this trial than it was in, I think it's Amelia, potentially. And I can link that trial at the end in our description when we put this up. The second thing to talk about is HER2 positivity. Usually what happens, and for someone to be eligible for trastuzumab and pertuzumab, they have to have HER2 FISH, so fluorescent in situ hybridization of positivity, or I guess HER2 IHC of 3+. Sometimes they do something called CISH, but I'm not going to get into that. That's when there's an equivocal or you're not sure of the results. This whole area is currently changing, and the reason for that is Destiny Breast 4. There's lots of Destinies. There's lots of breasts. They've got Destinies across lots of different cancer subtypes, but they're looking at using trastuzumab deruxtecan in low HER2 positivity just because of the affinity of this drug. We think it could potentially help this cohort of patients as well. So watch the space. It's very exciting, and I expect that in a couple of years we won't be worrying as much about the HER2 positivity as long as there is some element of HER2 positivity.
Absolutely. Very, very exciting. I'm sure we will do a podcast episode on Destiny Breast 4 just because it is such a game changer for so many people that would otherwise have been deemed quote unquote HER2 negative. I did look this up. I think it's about 37% of all breast cancers have some HER2 positivity. And all of a sudden you've got this fantastic drug that can be used for them as well. So it's what I'm going to coin in a world first. I'm going to coin the breast cancer syndrome, where there are just more and more lines of really, really good treatment, which means that we can start pushing out the survival to a truly ridiculous degree. And so it really is a testament to everybody who's worked on these drugs that we have had the results that we have with them.
That's it. And my final points that I was holding the best to last, Mikey.
Best till last. How could you beat what you've already had?
A trend of overall survival was shown, but almost all patients, 96.6%, had disease control with trastuzumab. And Complete response was seen in 16.1% versus 8.7%.
16%. Wow. And let's just remind our listeners that these are not good players. These aren't people who have one spot of metastatic disease. These are people who have brain mets, who have liver mets, bone mets, the whole shebang. And, we're looking at a almost 20% complete response rate. That is just incredible. You really did save the best till last, Josh.
I did. I just needed to make that. Hopefully, you're still listening, but this is the stat you want to tell your patients.
Absolutely. Well, that actually turned out to be a very positive and hopeful episode, regardless of how it started. But let's just sum this up. So, HER2 positive breast cancer has fantastic treatments and new treatments coming down the pipe. The standard of care in the first line setting at this point is docetaxel plus dual HER2 blockade with pertuzumab and trastuzumab. But watch out for trastuzumab deruxtecan because it's coming for that dual HER2 blockade and it's lunch money.
It really is. And it's probably also coming for every single cancer subtype that has HER2 positivity.
And that's not even a exaggeration. We'll be seeing that many jokes have been made that we should have all bought shares in the companies that developed trastuzumab deruxtecan because it is going to be everywhere. It truly is the one direction of cancer therapies. Well, thank you very much, Josh, and thank you all for listening. Join us next week as we take a rather darker turn, if one can be believed, for an oncology podcast. We talk about the Mount Everest of current oncology, and that is the unassailable, untreatable pancreatic cancer. So we'll see you then. Goodbye.